Good morning, everyone. Thank you for joining today's Insight APSAD webinar series. My name is Michelle Taylor and I'm a clinical educator and occupational therapist working at Insight, and I will be your MC for today. For today's webinar, Harnessing the Power of the Lived Experience Voice. And before we go any further, I wish to respectfully acknowledge the traditional owners and custodians of the land on which I am speaking to you from and upon which all of you are joining us from today or viewing from later on, and pay respects to elders past, present and future, and to extend that respect to First Nations peoples who are here with us or watching later on. I'd also like to take a moment to recognise those with lived and living experience who we work with, who have the experiences of substance use issues, mental health issues, trauma, suicidality, and all of those who support them, and the contributions they make and the wisdom they bring and the ways that we can learn from them, which is I guess a segue, an appropriate one into today's topic, which I'm really excited to learn more about. So I would like to introduce you to our two presenters. We have Victoria Kostadinov from NCETA, who is a Senior Research Officer. And Victoria holds a master's degree in Organisational Psychology. And her research interests include the social determinants of alcohol and drug use, and particularly the role of the workplace. And we have Jack Nagle joining us. Jack is a recovering drug user and addiction treatment professional. In 2014, he founded Real Drug Talk, an organisation which seeks to change the perceptions around addiction so that stigma can be reduced and eliminated, allowing individuals affected by addiction to gain hope and help without fear of judgment and consequence. And today, they're going to speak to you on this topic, an introduction to the lived experiences within the AOD sector, within our workforce group, what that, the importance of that, and some of the challenges about that on an individual and organisational level. And they'll be sharing their recent research that's going to help us understand more about the profile of that group and what we can be doing going forward into the future. So I am going to hand over now, and as I do, I would just like to let people online know that I'll be monitoring the chat. So we will have some time at the end. If you would like to pose a question, make comment, I will be looking at those, and I will see you again at the end of today's session. So welcome, Victoria and Jack, over to you.
Morning, everyone. Thanks, Michelle. It's lovely to be here. Thanks so much to Insight for inviting us to talk today. Before we begin, we would also like to acknowledge the traditional owners of the lands that we're speaking from today. So in my case, I'm located on Kaurna lands, and Jack is speaking from the lands of the Wurundjeri people. And we'd like to pay our respects to elders past, present, and emerging as well. So by way of background, before we begin, we'll just give a really quick introduction, building on what Michelle was saying before. So my name's Victoria. I'm a Senior Research Officer at the National Centre for Education and Training on Addiction, located at Flinders University. I've worked at NCETA for about 9 years or so now, and I've also just started doing a PhD there as well. So as Michelle said, my work focuses primarily on the role of the workplace in alcohol and other drug use, as well as the characteristics and workforce development needs of alcohol and drug workers. And recently that's included a special focus on the needs of peer workers and workers with lived and living experience. And at this point, I'll just also really quickly acknowledge the Australian Government Department of Health who fund NCETA, as well as the other team members who've been working in this area with me, primarily Natalie, Vanita, and Jackie. Jack?
Hi, good morning, everyone. Thanks for having me on. I'll talk a little bit more about my background in this space in future slides because it ties in a little bit to what I want to talk about today. But basically, I'm a person that has consumed services after having issues with drug and alcohol, and then found myself in a position advocating on different levels. And someone that's really passionate about lived experience workforce due to the positive experiences that I had. And I've been working in different capacities in the AOD sector. And currently we run our own private practice. So that's me, but I'm looking forward to talking a little bit more about that soon.
So today we're going to be speaking about harnessing the power of the lived experience voice. So we'll begin by giving a little bit of an overview of exactly what we mean when we say lived experience and how workers with lived and living experience differ from peer workers. And Jack's going to speak to you about what workers with lived and living experience do, why they're so important for the AOD field, but also some of the challenges that they face in their jobs. I'll then take you through some of the organisational challenges that the AOD field is grappling with in terms of utilising workers with lived experience, and give you an overview of a survey we did of workers with lived experience and its results. And finally, Jack will finish off by laying out a vision of where we'd like to see the AOD field go in terms of best supporting and utilising workers with lived and living experience. And we'll try and leave plenty of time for questions at the end as well. Alrighty, over to you, Jack.
Okay, so look, I'd just like to start as well. Something that I always mention in this space is that I'm just going to talk a lot from my own experience as well throughout the slides and some of the situations I found myself in. But in no means do I speak for everybody because everybody does actually have a different experience. With alcohol and drugs, service, consuming services, all that sort of stuff. So I always just like to make that clear. And it's something that I found really exciting actually, since working a little bit in this space, is the different ideas and experiences that people have to bring to the table. And also I apologize because my son is 15 months old and he's in that stage where he's getting every little sickness you can think of, and I've got a little bit of a frog in my throat today, so if I have to frantically sip on water, I will. And I probably just like to start with a definition that I like, just as a bit of a history. As a lot of people might know, I guess from my perspective, there has been lots of progression in the lived and living experience worker space and peer workers and all that sort of stuff, which is awesome. But in terms of a formalized, laid out structure nationally, I'd probably still say that it's at its infancy. And I've noticed just talking to lots of different people, there's lots of different definitions and lots of different ideas about how that should all run. So this is just one definition that I like. And it does actually have a little bit of a mental health lens on it as well, which I'll talk a little bit about too, and how we can maybe go about separating each of the workforces and I guess specializing with the AOD stuff. But this is one that I like. This is from the Lived Experience Leadership, who do a lot of research into lived experience, both in mental health and AOD. But lived experience workers have had a life-changing personal experience with mental health and or alcohol and other drug use, accessing support services, had periods of healing / recovery, and are employed in diverse roles to use their lived expertise to help other people access services. So I really like that one. And I just think the first thing that is I always like to talk to professionals about is that people with lived experience aren't trying to take over the whole workforce. It's actually just another piece of the puzzle and its own stream, if you like, and something that can help and aid. And really, I think it's lived experience and defining it for me is not so much about what someone's specific experience might be, but how they can use, I guess, those feelings, insights, perceptions, all that sort of stuff, experience, to help other people, I guess, come to a more positive outcome or place with the service that they're accessing or the situation that they're in. So, and the exciting thing for me about peer workers or people with a lived experience is that they're incredibly passionate, and it's really a group of people that's really keen to help and support and be in the field of AOD, which I know that Victoria is going to talk a little bit more about, but something that is a bit of a concern with workforce in general is people leaving the workforce and needing more people in the workforce. So I think the other thing to mention is that there's lots of unique perspectives within the lived experience workforce, and there's lots of different issues to think about. I think that a lot of people initially, when they think of someone that has a lived experience or peer workers or whatever you want to call it, is that that's someone that just works in, say, like a rehab and maybe supports people within that service. That's the common thing that I hear. But yeah, just thinking about all the different types of services that peer workers can integrate within and how they can help service consumers to have a more positive outcome with those services and in their life. And obviously I'm going to talk about that in challenges, but yeah, that gets really interesting and tricky. I guess when you have someone that may still be using drugs, that can be considered a peer worker in different services, and you know, things like that. So I think there's lots of unique perspectives that can be gained. They're passionate people, and it's really just another piece of the puzzle. But I think one of the things that's very important is to have a national definition that we all come to that, creates a separate stream for people to be in those specific identified roles. I think you're in charge of the slides, Victoria.
Yep. So I'm just going to jump in really quickly at this point and add a little bit of extra context in terms of where peer workers and workers with lived and lived experience sit in the broader AOD workforce, just building on what Jack was talking about there. So just in case anyone watching isn't really familiar with the workforce, basically it's made up of both specialist and generalist workers. So specialist workers are those whose core role is preventing or responding to harms from alcohol and drug use. And those workers are supported by a broader range of generalist workers. So these are people who are employed in roles that don't specifically address alcohol or drug use, but who nonetheless regularly encounter it and can play a really important role in preventing and minimizing harms. So for example, through screening and referral. So peer workers generally sit pretty neatly within the specialist workforce. They're employed in specialized, dedicated peer roles, often in mainstream treatment services, and they often work alongside other specialist workers. But by contrast, workers with lived and living experience can fit into any of these categories in either the specialist or the generalist workforce. So unlike peer workers, they aren't in specified or identified roles. They work as counsellors or social workers or psychologists or whatever their job description is. They just also happen to draw on their experiential knowledge in doing so. And I just mentioned this because it's really important to keep this ambiguity and this diversity in mind that we see within the lived experience workforce, as it's in many ways really beneficial, but it can also exacerbate some of the professional challenges that they face. So back to you, Jack.
Okay. So this is something that I find really interesting out of the National AOD Workers Survey from 2019, is that 60% of the workforce identified as having a lived experience. As you can see there, 33% family or other, or 35% personal, and only 2% of the workforce was in designated peer roles and positions. And that's really, I think, as Victoria was just talking about, an important question and conversation that has to happen about, the different ways in which we define roles for people moving forward, because there may be some people that, do want to use their lived experience, but also want to hold that professional role as well. And there's people that want to be in designated roles too. And I think there's space for both. So just quickly, I think it's interesting to kind of explain. So I got into the AOD workforce about roughly 8 years ago now, or 9 years ago. And that was off the back of me accessing services and being inspired by the people that had lived experience in those services. Really, it changed the course of my life, not only from the help that it gave me accessing the service and getting better and allowing me to trust and, all that sort of stuff, but also, my future career progression and helping me to develop, all the other stuff that was going on in my life that needed to change. So, I think that's really interesting. And the thing that I've noticed, which is really cool to see change, is that at that time when I accessed those services, I'm from Melbourne, Victoria, I tried to access a couple of different public services, and I don't know, I found this with a lot of people, just talking to people anecdotally, but I was definitely like this. I'm not saying everybody's like this, but when I was using drugs, I had this kind of arrogance about me, and I thought that no one understood me. And when I reached out to different outreach youth services for help, and I just got a professional on the phone, I often wouldn't connect and wouldn't re-engage in that service. And it wasn't until I met someone that had a lived experience that they didn't heal me or fix me or anything like that, but they just, by sharing their story and their experiences, were able to open up the window for me to trust that the clinical services could work, because I heard their story and saw that they did it and thought that I could do it too. So the interesting thing about that was actually in a private service. And I've found that is more of the case. Definitely here in Victoria, is because there isn't heaps of established, and it's changing now, which is really exciting to see, but because there isn't heaps of established roles and I guess frameworks and some of the challenges addressed to allow workers within the system to disclose their lived experience, I guess there's a lot of that showing up in the private sector. And that's why I've been really keen to help develop that in the public sector and non-government services and all that sort of stuff, because again, anecdotally, and I'm excited to see more research around it, but so many people that I talk to just describe that one of the things that really helped them in their service outcomes, whatever that might be, was engaging with someone that had a lived experience and hearing how that can help them. But not only that, then the willingness for that person then to go on and be encouraged into employment and being involved in the AOD sector. And again, not saying that everybody has to do that, but that's definitely something that has been highlighted a lot in for myself and different people that I talk to. And I think it's a really interesting passion that we can leverage off people that are moving into the workforce, and really creates a win-win with the positive outcomes that can happen for service consumers, but then also having a group of people that are really keen to get involved in the workforce and creating different pathways for them. So the other thing that I think it can really help with at a level of policy and advice to governments and things like that is the breakdown of stigma. My experience, and most people tend to agree with me, is that the biggest problem we have is stigma on all different levels within services and the workforce and all that sort of stuff. And I've been really lucky through the years, which I'll talk a little bit about in a second, but to just find myself in positions where I'm on high level advisory committees and things like that. And it's been interesting as someone with a lived experience going in and sitting with a bunch of like professors and people that have like really hard degrees and, you know, all that sort of stuff, and politicians and whatnot. And just seeing, not saying that I'm special, I've seen other people do it as well, but just, you know, kind of bringing that human element into that space. And just seeing the kind of cut through that it has when particularly, you know, politicians and decision makers connect on that human level. Maybe they can relate it back to a family member or something like that, and how that just has like changed the perceptions of that people have around people that use drugs and alcohol, or drugs and alcohol in general, or people that work in the drug and alcohol workforce, you know, all that sort of stuff. So I think it's a really interesting piece of the puzzle that's exciting to develop, because it's just going to have a lot of second and third consequences as well that's going to help the AOD sector. So I just wanted to talk about as well, this is me when I had some hair. I've actively tried to stop doing this kind of stuff a little bit, because it's been 11 years, and I think it's a bit weird to keep talking about your story. That's just me, 11 years on, but also it's actually been really hard on me personally and on my family as well. So this was back, some of these photos are from back in 2015, roughly, when like I always do the inverted commas, like the ice epidemic was happening and the media was going nuts. And basically what happened was, it's kind of a double-edged sword. I really have enjoyed sharing my story in media, but it's been a massive learning experience and something that's been really challenging. And even though I did a lot of this media fully informed, now that I'm, even though I work in the space and all that kind of stuff, now that I'm like 5 years down the track, I've sort of pigeonholed myself in a lot of ways to a lot of other people as the ice addict, right? Like I looking back on it, I wish I had probably some different voices and some different perspectives to help me do it differently. But the plus side of it has been how many people I feel like I've been able to positively impact and help, and also some of the places and positions it's helped me to get to talk and see a little bit of the change that I want to see in the world or the sector. So I think it's really interesting to talk about the challenges and be really realistic about some of the barriers and harms really that can come from having a lived experience workforce, having people in all different positions sharing their story. And the other thing about all that media stuff is, which I've learned now, which has been really interesting, is probably in a lot of ways by doing a lot of the media that I did, and without having any training, and just being a naive guy that wanted to like help, I probably actually perpetuated stigma through the way that I shared my story and things like that. So yeah, I think it's really interesting to be realistic about how we help people to share their lived experience, be involved with different services, media, breaking down stigma, all that sort of stuff. So these, I think, are some of the key points that we have to think about for challenges for individuals. So keeping professional and personal boundaries within a recovery community. So just quickly on this, sorry, Victoria, I'm banging on a little bit here, but a lot of people that come into the AOD workforce that have a lived experience may be involved in some kind of like recovery community, whether that's like 12-step programs, smart recovery, or some other community group. And usually that happens at a local area, and that's powerful. And there becomes this whole question about how do you help people to I guess, keep going with their own recovery journey and go to those spaces that they need to go, and share what they need to share as an individual, but then separate that at work and seeing those people in those different environments, seeing clients, all that kind of stuff. That's a very real challenge that can happen. Also having adequate supervision. I feel like I've learned a lot of stuff on the run. And again, I almost wish I came into my whole journey with how the structures are now, because there's a bit more stuff out there. But yeah, just having like, it happens for all people, but you know, obviously through my drug and alcohol use, I experienced different things, and sometimes when I was working with people, it could be incredibly triggering, and not always having that person. I did have, you know, normal supervision, but not always having that person to kind of connect on that deep level and understand it from that lived experience point of view is really important as well. I guess this is something, the next point, which is really challenging for a lot of people, is navigating the different understandings of, I don't really like the word recovery, to be honest with you, but recovery, or ideas about addiction, or ideas about how people change. Sometimes when you have a life-changing experience and something's really worked for you in your life, you can be very passionate about that, but helping people to understand that there's lots of different pathways to people changing, and lots of different circumstances and situations that people can be in is really important. Helping people to work out what might be appropriate and what's not appropriate to disclose. Again, the challenges around long-term consequences for individuals, and how we can help people think about this in a longer term view, a little bit like I was talking about with the media that I did. There's even though it's a very exciting space, which I highlighted earlier, and I'm really keen to see more things happen, there is a lot of challenges. I think that there needs to be a really realistic and mature conversation had around those elements to help people consuming services, but probably more important, really keep the people safe that are the lived experience workers or peer workers. Yeah.
Alrighty, excuse me. So there are also, in addition to the things that Jack was discussing, a number of challenges more from an organizational or a sectoral perspective that we're facing in terms of how we can best understand, support, and utilize workers with lived and living experience. And as Jack was mentioning, a lot of these stem from the lack of a nationally consistent definition. So it's basically up to individual employees and organizations to decide what constitutes peer work or lived experience work. And this means that people from all around Australia may call themselves peer workers or identify as having lived experience, but their background, expertise, skills, and work role can vary enormously. And because of this ambiguity, we don't actually know how many peer workers or workers with lived experience there are in Australia. We don't know where they work, what qualifications they have, or what roles they perform. We don't know what kind of professional development supports they need in order to do their jobs to the best of their ability. So we don't really know anything about this entire cohort of workers. Now, compare this with many other professions in the health sector, where workers have to obtain specific qualifications, or at least formally demonstrate that they have equivalent skills and experience. They have to register with a professional body, and they have to complete regular professional development to keep their skills current. There are certainly advantages to this type of approach in terms of keeping track of how many workers there are, and ensuring consistent and high quality client care. But on the other hand, it also does place a lot of limitations and restrictions on who can enter the profession and how work is allowed to be carried out. So the question that we're grappling with at this point is this the type of direction that the peer and lived experience workforce should be heading in? And we'll get back to this point a little bit later. So there are a number of reasons why we should be concerned about how little we know about peer workers and workers with lived and living experience. For one thing, it implies that these workers aren't legitimate or important members of the workforce, and it perpetuates and reinforces the stigma surrounding alcohol and drug use that Jack was talking about, and that we know is already a huge challenge for these workers. But it also makes it really difficult to make workforce planning decisions. So if we don't know the size and distribution of the current workforce or what types of skills and expertise they have, then we can't effectively deploy current workers or plan for how many workers we'll need into the future. And finally, all workers are entitled to ongoing professional development activities to increase their skills and knowledge, pave way for career progression, and ensure high quality client care. But if we don't have a good sense of where peer workers and workers with lived and living experience are, or what kind of professional development activities and supports they need, then we can't provide them in any kind of systematic way. And this puts these workers at a disadvantage compared to other specialist AOD workers. And it goes back to my previous point about implying that they're less legitimate or important. And this is even more problematic because lived experience workers can face a number of unique challenges, as Jack was talking about. So we end up with a group of workers who are likely to struggle with things like role ambiguity, with work-life conflict. They're probably likely to be paid less, and they're likely to be the subject of stigma and discrimination. But we don't have any good or consistent ways to help them deal with these issues from an organisational perspective. And as you can imagine, all of this ambiguity makes it really hard to conduct research on workers with lived and living experience. And that lack of research means we know even less about them, and so the cycle continues. We have started to see a little bit of research crop up in the past few years, which is really great. But this is typically just focused on single jurisdictions or sectors. So to try and combat this, in 2019, NCETA conducted a national survey of the alcohol and drug workforce in Australia. So we surveyed more than 1,500 alcohol and drug workers across all states and territories, and in both government and non-government organisations. But for the analyses that I'm talking about today, we only included 986 workers who were in direct client service roles. So as part of that survey, we asked respondents the usual questions about their personal and professional demographic characteristics, their workforce development needs, and their health and well-being. But we also asked if they identified as having lived experience in relation to alcohol or other drug issues. And respondents could select that they themselves had personal lived experience, they had experience with a family member or someone else experiencing alcohol and drug issues, or no lived experience. I'll just point out in this question that we specifically asked about problematic alcohol and drug use. So if this definition was broadened to include use that respondents did not consider to be problematic, the proportion of lived experience workers would no doubt increase. And these are the research questions that we were interested in for lived experience workers specifically. So we wanted to know how prevalent lived experience was across all workers, and not just how many people were in designated peer roles. So this is an important distinction because typically most research to date has tended to focus on peer workers specifically. And we also wanted to know what lived experience workers tended to look like and whether this was different from workers with no lived experience. And finally, we wanted to think about the implications of this for work well-being in terms of burnout and engagement. And this is what we found. As Jack mentioned earlier, there were 2% of workers in our survey who were in direct client service roles that were designated as peer positions. But compared to that, a whopping 67% reported some sort of lived experience. There was a fairly even split between those who had personal lived experience and those with family or other types of experience. Now, we didn't find huge differences between the demographic and work characteristics of workers with and without lived experience. These ones that I have on the slide are the only statistically significant differences that we found. So workers with lived experience were less likely to have tertiary qualifications, more likely to be employed in the non-government sector, more likely to report job insecurity, but also more likely to report that they found the work that they did very meaningful. When we looked at levels of burnout, engagement, and turnover intention, we again found that they were really, really similar between workers with and without lived experience. So on the one hand, it's good news that workers with lived experience in this study don't seem disproportionately prone to burnout. But on the other hand, it's pretty concerning that rates of burnout are this high across the entire workforce. And I think that the AOD sector as a whole is pretty well aware that this is something that needs to be addressed. I do think it's interesting that although workers with lived experience were more likely to report meaningful work, as I showed on the previous slide, but this doesn't seem to be translating to higher levels of work engagement. So we're not really sure what's going on here. It's possible that while the work itself is really, really personally meaningful and fulfilling, there are structural or organizational challenges that are lowering engagement levels. So for example, the higher levels of job insecurity that we found might be playing a role here. The other thing that we asked participants in relation to their well-being was the type of organizational supports that they thought would be beneficial and whether or not they currently had any access to those supports. So the table on the right here shows the results just for workers with lived experience. And you can see that informal support was considered to be beneficial by most participants and was also able to be accessed by most participants. So that's really great. But things like debriefings, counselling, support groups, all had lower, relatively speaking, levels of availability and accessibility. So I just wanted to highlight these as being a potential really good starting point for organisations who are wanting to support their workers with lived and living experience. Implementing and expanding access to these types of progress could be a really good place to start. The next thing we looked at was the variables that predict burnout and engagement among workers with and without lived experience. So these are the factors that we included in the models, and you can see we included, as you'd expect, the basic socio-demographic characteristics and also variables related to job quality. So this is the predictors of burnout on this slide. And once again, the results are not super different between the two groups. For workers in both groups, burnout was more likely among those who were younger and who experienced greater work intensity, as you'd expect. And for workers without lived experience, burnout was also related to lower levels of respect and support and lower levels of organisational openness to change. And looking at engagement, meaningful work was associated with higher levels of engagement for workers from both groups, while job insecurity and organisational openness to change also predicted engagement for workers without lived experience. And finally, respect and support from colleagues predicted engagement for workers with lived experience only. Now, this latter finding, I think, is a particularly interesting one because it's the only predictor we found that was unique to workers with lived experience. So ensuring a respectful and supportive environment might be, again, a good starting point for interventions which want to reach this group of workers specifically. But it does seem in general that well-being among workers with lived experience is pretty similar to those without, and predicted by pretty much the same sort of variables that you'd expect. Now, these results might not seem particularly groundbreaking, but they do provide some reassurance for the first time that initiatives to promote work well-being by targeting these sorts of factors are likely to be effective for workers with lived experience as well as for those without. And this is really important for organisations to know who are looking to enhance well-being in order to promote better retention. Having said that, I would again like to stress how little we continue to know about this segment of the workforce and how best to support them. So we found that only half of the workers are engaged and half are feeling burnt out. How can we improve these numbers? What can we do? What types of strategies are going to be acceptable and feasible for both workers and organisations? So to answer these sorts of questions, I think we really need more research. This study was a good start, but it wasn't a huge sample. It wasn't representative, and getting good quality data from this sector is really hard. And also in the future, I think it's really important that future research is conducted with lived experience workers and not just on them. And Jack's going to talk about this point a little bit more later as well. So the final thing that we asked in our survey of workers with lived experience was whether they had disclosed this lived experience to their workplace, and if they hadn't, why they hadn't done so. Now, as Jack mentioned earlier, disclosure can be a really tricky issue to navigate, and we found that about 1/3 of workers had not disclosed their lived experience, and that this was more common among those with family or other types of lived experience as opposed to personal lived experience. But when we look at the reasons for non-disclosure, it becomes clear that while fewer people with family lived experience disclosed, this was generally because they didn't see it as particularly relevant. But by contrast, when people with personal lived experience didn't disclose, it's because they were worried about experiencing stigma and worried about protecting their privacy. So there are a couple of key messages that we took away from these survey results. Firstly, there seems to be a really big disparity between the number of designated peer positions and the number of AOD workers with lived or living experience. This isn't necessarily a bad thing in and of itself, but it does mean that we can't use the number of peer roles as a metric for the size of the lived experience workforce, and we can't make any workforce planning or workforce development decisions based on that number. And secondly, we want to be able to provide professional development opportunities and formal organisational supports to help workers with lived experience to leverage and utilise that experience as well as possible. But again, we can't just provide these supports to peer workers because that will exclude the vast majority of workers with lived experience. At the same time, we obviously don't want to force people to disclose their lived experience in order to get access to these supports. So I don't really have any answers for this at this point. I just think that it's something that the sector needs to think about really, really carefully and hopefully come up with some way of implementing these supports without compromising personal privacy and autonomy. And finally, a really substantial proportion of workers don't want to disclose their lived experience because they're afraid of being stigmatized. Now, this is obviously unacceptable anywhere, but it does seem particularly absurd and tragic in the alcohol and drug industry. So we really need more research into how, where, and why the stigma is occurring, and we need resources and we need large-scale campaigns and initiatives to address it. So I'll hand it back over to Jack now, who's going to finish up with some key steps that the sector can take to support workers with lived experience.
Thanks for that. So I think, a couple of things that I'd just like to highlight that I keep pushing is that there is well, I know the state that I'm from in Victoria, there's a lot of excitement around lived experience and the peer workforce and all that type of stuff, which is fantastic. And I think that's the case all over Australia, really. But it would just be good for everyone to just kind of pull the reins a little bit and hold up slowly, in my opinion, because it is such a emerging space. I think it's awesome that each different state or jurisdiction does their own localized initiatives, which is fantastic. But just the early work, I would really love to see it done more on a national level, from a collaborative basis, so that there can just be some baselines established by everybody, so that then there's a bit of a platform to launch from. Because the thing that I would hate to see, because I think it would hinder the positive progress of the workforce, is for, I'm just using hypotheticals here, but Victoria to kind of get halfway down the road with one way of thinking about things, and WA coming up with something completely different, and Adelaide doing something slightly different again. And then there's confusion, conflict, all that sort of stuff, and it just holds things up. So that's the first thing. I would love to see a national consensus, and I think that's really important to move forward. Because of all the challenges that we spoke about, and there's much more, I really think one of the first steps that could happen to keep people safe, and to also further define, the peer workforce as separate from lived experience and specialize the whole workforce in general, is to really get a nationally accredited peer training, again, that has that consensus, that can then off the back of that, then we can see roles being defined throughout organizations throughout the country, without the onus being left to organizations to organize that, come up with their own boundaries and guidelines around it. I think it would just leapfrog things and progress it a lot further. The other thing that I think is really important to make sure that we're I suppose doing this in a safe way is building the evidence base. So I hate to be evidence limited, but because sometimes I think we can fall into that category. We don't have enough evidence to do something. But I think with the workforce, because it is so emerging, I think simultaneously there does have to be the building of the Australian evidence base, to really, actually establish what's effective, what's not effective, what's helping, what's hindering, all that sort of stuff. And, I think what will also happen as we keep building the evidence base is that we continue to elevate the importance of peer workers, or lived experience workers, and the importance of their role, which then in hand elevates, the I guess the importance that's put on them from a financial remuneration perspective, support perspective, all that sort of stuff. So even though I find the research process can be a bit frustrating, funny thing to say on a Insight webinar, I know, but it's super important, I think, in this case, to help raise the profile and specialize the peer workforce and the lived experience workforce. And I also think, getting a bit creative and embedding peers in a lot of different levels of, the alcohol and drug sector, from research to, policy advice to service innovation, service delivery, and really, including peers on the whole process. And actually, if someone's on an advisory committee or whatever it might be, paying people for that expertise that they bring, because it really is expertise, and it's a big thing for people to go and share, their life and contextualize it in the policy setting or whatever it might be. So it's just something for everyone that I'd love if there's any professionals or anyone involved in putting together these bodies and boards. There's a hashtag going around at the moment. I'll probably butcher it, but it's a common saying in this space. nothing about us without us, or something like that. I probably got it wrong. But that's really important, because I found that it's changed a little bit now, and I've had some really good experience, but I've also had some negative experiences as well, where I just kind of am put on a committee or an advisory group or part of some service innovation design or whatever it might be, and I'm really just there as like a token. And I feel like that. But then I've really noticed the difference when there's other experience, when I've had other experiences where I'm really a part of the whole process, and I'm brought along and valued for the experience that I bring. So they're the things that I would love to see as an initial menu. It's a lot to kind of digest and do, but I just think all of these measures would help to elevate and move the workforce forward.
I think that's pretty much all from us. There's our contact details if you want to get in touch. And we'd be happy to take some questions.
Well, thank you so much, Victoria and Jack. It feels like in some ways you're charting this, really essential territory for us, and giving us more of the map so that we, know where we are and know where we could be going. There's a lot of appreciation on the chat. I'm not sure if you've been following it, and quite a few questions. So I will endeavour, some have sort of been answered, and I will pick a few out and see if we can get through a few. Look, there's a question from Richie, who's working with someone who's interested in volunteering in a capacity as someone with lived experience. And they mentioned the hesitancy around that, sort of not being sure at what stage of recovery you might need to be at to be able to do that. What about issues like relapse? So they were just seeking any ideas that you have to tell people like that.
Yeah, it's a great question. Again, that's something that really needs to be grappled with quickly, and I think some work and frameworks done around it to help organizations manage those concerns of individuals, because it's really real. I would say that first things first, in my experience with it, is you kind of have to go back to basics and really understand if you feel like you're ready to engage in that first and foremost, that type of work with the supports that you trust, before considering any of the other stuff. Is this the right time? All of that. Am I emotionally and mentally in a space where I feel like I can go and do that? And I would probably say, if that's yes, there's, I don't think there's any time limit. I've spoken to people that say, that people early on help a lot more than, say, someone in that's been, in recovery for 11 years, because they're a lot closer to it. But I would say that there's lots of concerns, and that maybe it's good to start small and really explore your options and ask questions of the service and what they might need and how you could help. I hope that answers the question. I feel like I sat on the fence a little bit with that one, but yeah.
That was really helpful. And some people are putting things in the chat too. There's an intentional peer support org trainings. There's a link that's just been dropped in there. It kind of reverberates with some of the things people are saying too, Jack and Victoria, that, appreciating the strengths and the vulnerabilities that can come with this work, and how we, having things in place to really support well-being is so important to grapple with and plan for. Look, there's another question. Maureen says that if you're a professional, disclosing around your lived experience, that's something that people might need to be really careful of with regards to their professional bodies. And another person, Susan, said that, there's also broader disadvantages sometimes in disclosure around health and life insurance and those bigger pictures. So just wondering if you have any tips or thoughts around that and where that might go.
Do you want to have a shot, Victoria?
I might leave that one to you, Jack.
Yeah. So I think again for me, and I'm sorry because I do feel like I'm sitting on the fence, but it's why I'm excited to do these kind of webinars and talk about this stuff, is that I really think it's a big question and a hard thing to consider, and at the moment it's really left to the individual to work out and decide and to feel comfortable. But I really do think that there needs to be some clearer boundaries and structural frameworks, or whatever you want to call it, put in place to help people navigate that. Because if I'm being completely honest, I'm not even sure about a lot of that stuff sometimes for myself, and I have to go and talk to the people that support me and supervise me to help me. So yeah, again, like I would just, if there's anyone on the call, would just push anyone to help spread the message that we need these frameworks and stuff in place to help people make those decisions. But again, a really good support network around you that you trust, that you can bounce off to help you understand what you might feel comfortable with and what's appropriate in a clinical setting. Yeah.
Thank you. And I guess it highlights sort of where we're at and why your work is important for starting these discussions and advancing them. One other question is around courses, education and training. This is from Mark, and some other people have mentioned this. Just wondering about any of your thoughts on that, how they could be improved or, incorporate the sorts of parts that you've been talking about today, paying attention to this big important part of our workforce who have these experiences.
Is that me again, Victoria?
I think it might be, I'm afraid.
Okay. So yeah, like I have a lot of thoughts on this actually. And again, I think I kind of mentioned this throughout the presentation. This isn't to diminish any of the work that anyone's already done, because there's lots of brilliant work that's been done across Australia on different courses and stuff like that. But I think one of the things that I probably didn't highlight in the presentation that I'm very big on and conscious not to happen is that that we don't kind of just get sucked into the mental health peer support courses, because I think it is different and there's different elements that come into it. So I think for me, the biggest thing that I would love to see happen is, I don't have all the answers. I'm not an expert. I think it has to be a collaborative thing that happens nationally, because there is like I've spoken to so many people about this on many different levels that that have different opinions and different ideas on how it should look and how it should happen, and all those opinions need to be heard. So yeah, I would love to see almost like a national what do they call them, like conversation paper or feedback paper or something like that gets all the views from everyone, and then from there there's like a tailored and specific course outline that's developed and put forward to be delivered as whatever, I don't know, a TAFE course in whatever capacity that is. But again, I would love to see it specific to alcohol and drugs. And I don't think that we have that yet. Yeah.
Yes, and I think you mentioned there's no consensus around a national definition, like a starting point at this point, because someone else was just clarifying that, and it sounded like that's the case. We're still heading there.
Yeah, to the best of my understanding, yeah. And again, like I think all the work that's already being done is amazing and can be taken and really used as a great head start. But yeah, there really does, from my perspective, need to be that national consensus. And I would love for everybody, if they could, to take that away out of this presentation, to give that as feedback as they're having the conversations, is how can we get everyone across the country having this conversation together to develop these whatever framework, guidelines, courses, so that we can have a really positive outcome for many, many years with the lived experience and peer workforce, rather than it being a bit higgledy-piggledy. Yeah.
Well, it's been a wonderful hour having your thoughts and these discussions presented to us, and people have your contacts there if they wish to get in touch. We hope to hear some more research on this in the future as well. So thank you, Victoria and Jack, very much for a wonderful presentation this morning. So much food for thought. And if you've had a chance to read the chat, there's lots going on there. So I'd encourage you to take a look there too.